talk that tells you how to approach poorly differentiated tumors. So let's just start with that. This is not a slide seminar in the usual sense of the term, and I think I will be talking to all of the young people who have introduced themselves just now, because through them I think the wider audience will be able to get an idea of what it is that we are trying to achieve. Okay, now let me see. All right, let us start with this question. Okay, what is differentiation? So Lalit, I have you at the top of my list over there. So Lalit, will you be able to tell me what is differentiation?
Yes, ma'am. The differentiation refers to the extent at which the neoplastic cells resembles the parental tissue.
All right,
and
so
loss of differentiation is known as anaplasia.
So you just repeat it. Sorry, I interrupted you, Lalit. So can you tell me what is differentiation?
Ma'am, extent to which the neoplastic cell resembles the corresponding normal tissue and loss of is known as anaplasia.
Okay, so now that is Lalit's definition of differentiation. Navneet, do you agree with that?
Yes.
Definition?
Yes, ma'am. It is the degree to which the tumor tissue is resembling the parent tissue.
All right, Sakshi, have you any other idea or any other definition of differentiation? And anybody who wishes to give a differentiation can put it in the chat box, and either Aarti or Tripura can tell us what they're saying. Okay, so let me go through my students that are there, who everybody is listening to. Yeah, come on, Sakshi.
Yes, ma'am. Differentiation means that how much the tumor resembles the parent tissue, and if we can tell the origin of the tumor cells and the maturation.
All right. So Sakshi has added an additional thing. All three of them are talking about tumor cells, how much they resemble their parent cells, and Sakshi has said it helps you to distinguish what the tumor is. Okay, Aradhana.
Ma'am, differentiation is a process by which cell acquires certain specific structure or function.
Okay, so Aradhana has taken off on a different path altogether. The previous three, that's Lalit, Navneet and Sakshi, talked about tumor differentiation. Yes, Aradhana for the first time now is saying something where she hasn't mentioned the word tumor at all. Okay, so let's ask Amrita. Amrita, are you there? Have you logged in? Can you say something? Can we hear you?
Yes,
very good. We can hear you. Come on.
It's the extent of tumor cell which resembles the lineage of origin, ma'am.
All right. So Amrita has also talked about differentiation as being part of a tumor. I saw something coming up in the chat box and I didn't catch who it was, but that person, and I also saw Rupinder Kaur, and she agrees with Aradhana, because so far out of the 5 people I have talked to, and I'll talk to the others like Deepak, there have been 4 who have talked about differentiation with respect to tumors. Only Aradhana, then I've seen some people in the chat box agreeing with Aradhana and saying that differentiation is not just a process that occurs in tumors. That differentiation is, Aradhana, would you like to repeat what you said so that everybody can hear?
Ma'am, differentiation is a process by which cell acquire certain specific structure or function.
Yes, so what you're saying is that it is a process, and that this process is a process by which cells acquire in a progressive kind of way the characteristics of you said structure and function. Yes, in other words, they have the characteristics of maturity. Deepak, who do you agree with? What is differentiation? Now you've got two definitions here. One is a tumor definition. It's all about how closely it resembles a normal tissue. And on the other hand, you have Aradhana, who said that it is a process. It's a process of acquiring structural or functional characters. So what do you think, Deepak?
No, I agree with Aradhana.
You agree with Aradhana? Yes.
When it acquires a specialized function.
Okay, so you're not talking about differentiation as it occurs in or does not occur in tumors. Am I getting you right, Deepak?
Yes, I'm talking about normal cell.
Okay, you're talking about normal cells. That's fair enough. But tumors also have some issue with differentiation, do they not?
Yes, ma'am.
Yeah, all right. So Aishwarya, what do you think?
Ma'am, I think it's a cell maturation process. It's a normal process, and eventually all the cells, they specialize, so they undergo differentiation. That's my take on it.
That's what you think. All right, yes, very good. And Sneha?
Ma'am, stem cell differentiate into various tissues and they perform their function after differentiating.
After they differentiate. All right. So I think that the best definition was that given by Aradhana and some people in the chat box. Aarti, would you like to say what's going on in the chat box, or Tripura?
Oh, yes.
Any definitions there?
A similar kind of definition of stem cell differentiate in various kind of cells by the process of differentiation by Dr. Manan. Then yes, sir, differentiation is when we can identify the lineage via its functional characteristics. Lalit, process by which cell acquire specific structure and function. Dr. Preeti, in context of neoplasia, differentiation is how closely tumor cells resemble the normal tissue from which it originates. And Rupinder Kaur, a process through which cell mature.
Yes.
Then Pavitra, ma'am, differentiation is a process of development or maturation.
Okay.
Then Tubali, process of specialization of cell. Then HT, unverified, resemblance to mature tissue from we can identify.
All right. So I think that most people in the chat box seem to have talked about differentiation as a process. So let's find out what differentiation is. And differentiation is indeed, and I must congratulate you, Aradhana, for having you did a little bit of reading and you came out with an idea. And I think this idea is that differentiation is indeed a process. It is a process of acquiring the features of maturity of an organ, cells or a life form. So organ, tissue, or a life form. Now, what do we mean by organ or a tissue or a life form? Now that Aradhana, you have set us on this path, what do we mean by a life form when we're talking about differentiation? Can you think? Huh? Aradhana, you were very good at giving us this. So is it only about cells, or is it about, can we talk about the formation of organs or the formation of tissues and even a life form? Now, I don't want to put you on the spot, but how did we, it could be me, it could be you or anybody, how do we become fully mature organism? I'm an organism, you're an organism, yes or no?
Yes, ma'am.
Yes, Pavitra is talking about evolution. Yes, evolution is also a process. But just talk about a zygote. Does a zygote differentiate or does it not? Yes or no?
Yes,
Huh?
ma'am.
Yes, it does. Okay, so a zygote, whether it is forming a human being or it is forming any other kind of organism, multicellular organism, it has to be multicellular. Otherwise, the question of differentiation does not arise, right? Should it not be multicellular? Can you have a differentiating amoeba? Yes, let's ask Aradhana, because she brought up this process of differentiation. Do you have an immature amoeba and a more mature, more differentiated amoeba? Is it likely?
Yes, ma'am.
Yes, you think so? Well, an amoeba is a single-celled structure. So what is going to differentiate in an amoeba? Okay, it's not really possible. So differentiation can only occur in a multicellular organism, right? So that each of the cells may have its own maturity and functionality. Well, it's the most poorly differentiated of multicellular organisms. If you maybe things like sponges, right? Sponges are polyphylla. You remember phylum polyphylla? Anyway, they have lots of different cells, and the different cells are all really different from one another, but they all have different functions. Now, what has happened over here? Like somebody said, stop broadcast. What is this
Yes,
about?
ma'am.
Huh? Everything on your screen, it's gone off.
I don't know what happened.
Anyway, never mind, I'll share it again.
So we'll have recording again, Ruchi.
It's okay. That's fine. Okay,
fine.
so now it's all right. So this is the process that is responsible for normal development. Whether it's coming from one cell that fully differentiates into all our different organs and tissues, or an individual tissue. When, say, the stem cell of an individual tissue is going to differentiate and form the cells of that particular tissue, or the stem cells of an organ then differentiate. Now, those stem cells themselves have become differentiated from an undifferentiated or a polyphenotypic cell, which is the germ cell. So differentiation can occur at many different time points in the development of an organism. So it is a process, and that is something that one has to realize. Now, you can have differentiation. You have it every day in the bone marrow. Okay, you've got there's a process of differentiation in your red blood. That means in the erythroid series, in the granulocytic series, in the megakaryocytic series. That process by which the stem cell of the erythroid series becomes a fully matured RBC. That is the process of differentiation. I hope that all of you are getting the point. If there are any questions and we haven't understood what is differentiation, I think we're going to have a lot of problems in trying to think about what is well and what is poorly differentiated as part of the tumor is. Are there any questions on this in the chat box?
No, ma'am, no questions. Only
Okay. So the process, differentiation is the process that is responsible for normal growth and development. Okay, and it goes awry. It is abnormal in growth disorders, and all growth disorders are not neoplasia. There are other disorders of growth, and I can't go into all the disorders of growth now, but there are other disorders of growth that can show you lags in differentiation or abnormal differentiation. Things like you have hamartomas and choristomas and all of this, which you can go and look up. And they're all disorders of growth, and neoplasia is the most important disorder of growth, which involves differentiation. Okay, so that's something that all of you are aware of, because many of you actually define the differentiation with respect to neoplasia, no? Because you said how much does that particular neoplastic growth resemble the tissue or the cell from which it actually arose. Now, I just want we start at the bottom now. Sneha, are you there, Sneha?
Yes, ma'am.
All right. You see these pictures over here? You've been looking at it for a long time. Okay, can you tell me what these pictures represent? I'm asking you, you're a PG3, right?
Yes, ma'am.
So tell me, what are these pictures? Starting from the left and going to the right. Do you recognize them? Do you recognize these pictures at all?
Ma'am, epithelial origin.
What? Sorry, I didn't hear that. What did you say, Sneha?
Ma'am,
Yes,
these are
ma'am.
like malignant,
This is malignant, but can you tell me?
pleomorphic
Right.
looking cells.
But you don't recognize anything in these four pictures, do you? Or anything that I've written on top what is differentiation, and we've described differentiation. So does anything strike you in this, Sneha, at all, Sneha? All right,
Yes,
so let's go the other way then. From Sneha, let's go to Lalit. Come on, Lalit. What do you see here in these four pictures? What is the connection you make between the first picture and the last picture and the two pictures in between? Are you there, Lalit?
Yes, ma'am. First one is look like poorly just a small round blue cell tumor.
All round blue cells. Very good, Lalit. Excellent. Yes. Then
And second one is, ma'am, glandular formation is there. So it's
glandular formation. Okay. Why do you say they're glands, Lalit? How does one recognize a gland? I see some people answering in the chat box. After they've answered, I'll tell you. After you have answered, I'll tell you, Lalit, what they're saying. Okay. See, you told me very correctly, Lalit, that we've got a small blue cell tumor on the left hand side. Yes.
Yes,
All right. Now, what do we have in the next picture?
ma'am, rosettes.
So now you're also looking at the chat box, huh? You
No,
said that it was,
I
no,
not.
you're not looking, very excellent, Lalit. But you said it was a gland. Now you have said
Yes,
it's a rosette. So why did you change from gland to rosette? In other words, what is it about this that is not a gland? Why?
Ma'am, empty
feel it is
looking.
not a gland?
Ma'am, lumen is empty and the
Lumen is empty. Glands also
yeah.
have empty lumen.
Yes.
You can't see very clearly over here, but the center of this thing is not empty. No, it has got a sort of pinkish hue. Oh.
Yes, ma'am.
Okay. So you correctly said it was rosette. Can anybody tell Lalit? Come on, Deepak. Tell Lalit why this is not a gland. I mean, he's now identified it as a rosette, yes, but he can't tell me why he has changed from gland to rosette. So come on now, Deepak.
Yes, ma'am.
Why is it not a gland? Say, suppose you were in my place and you had to tell him why is it not a gland. What would you say? No, you can't. All right, let's ask Aishwarya. Aishwarya, first of all, do you think it's a gland?
No, ma'am.
No. Okay. So why? There are some people in the chat box saying there is no glandular lining. And what is it then?
So actually, the epithelial is not.
You don't see an epithelium. Okay.
Glands usually have columnar epithelium.
So you're not seeing an epithelium. Very good. So this is not, you're not seeing an epithelium, but then sometimes we have to define epithelia, etc. Right? Okay. It's not a gland for a very good reason. In the center, of course, there is something. Maybe you can't see it very well. But if you had a gland, say this was all something that looked like a cribriform space or something of that sort, and if there was an outer part to this, suppose you had this is the outermost part of this gland. Okay. Should there not be some kind of limiting membrane or some kind of thing that tells you that something is a gland? It isn't there. So this is not a gland, and you have very rightly now Lalit called it a rosette. Okay, very good. So these are rosettes. So you had something that was small, blue, and looked very poorly differentiated. Now you've got rosettes, and the rosettes have got something in the center. And maybe this is not a very good picture, but there is neuropil in the center. Okay.
Yes,
now come on, Lalit, what's happened on the right hand side?
Ma'am, third image is poorly differentiated epithelial tumor.
Poorly differentiated epithelial tumor.
Yes,
Achha.
cord arrangement is there.
Cord-like arrangement.
Yes,
Okay. Everybody agrees with Lalit? Navneet, do you agree with Lalit?
Ma'am, we cannot see any specific pattern formation here.
Can't see specific pattern formation. Now remember, the first picture is just small round cells. The next picture has got rosettes with neuropil. And let's go, if possible, to the last picture. What do you see in the last picture? And then we'll talk about the third picture. Go on. What do you see in the last picture, Navneet?
Ma'am, all cells are of different size and have nuclear pleomorphism.
All right. And Navneet, I'll tell you that all these four pictures are related to one another. Now, what do you think all these four pictures actually mean? Huh? Yes, anybody. If it's not Navneet, then anybody. All the third year guys. Come on, Sakshi.
And third one is differentiated in squamous cells.
Squamous cells. Achha. And the
And
fourth
fourth one has mucin
mucin.
in the cells.
Okay, all right. Aradhana, do you agree? All these pictures are related to one another. There are small round cells, there are rosettes. Now somebody's saying that there is squamous cells and mucin. Does that make any sense to you, Aradhana? Small round cells, rosettes, and then squamous and mucin? Yes? Does it make sense to you?
Spindle cell.
Spindle cells. Can you point out a spindle cell to me, please? Now you know how to get annotation. Oh, lots of people have got very good ideas that are in the chat box. Huh? And they're correct. So now, very good. I have to approve. I approve. Come on. Now come on, show me spindle cells. Yes, there she is with her green pen. She has shown that there are spindle cells. So yes, you're right. Okay, so this is not anything to do with mucin, right? So you've got a cell. Now let me just take my pen and do this. Yeah, look at this cell. Everybody can see this, or maybe the white is not such a good idea. Let me take a green or something else. What cell do you think this looks like? Deepak? What does it look like? Ganglion cell. Very good. So we had a ganglion cell over there, and we had some spindle cells in this last picture. And we started off by round cells. Then we saw rosettes. Same round cells, but now they are forming rosettes. In this third picture, Deepak, what do you see? What do you see in the third picture? What? What do you see? You're seeing some cells. They are multinucleated cells with a lot of cytoplasm. And in the background, you are seeing this. What you're seeing are these small cells that look like what you were seeing in the first two pictures. Some of them are now beginning to become or be associated with these big cells, yes, which have very large nuclei with nucleoli, yes, except that they are and they've got a lot of cytoplasm. And when you go to the last picture, you see that the cells are, yes, the round cells are still there. Okay, you can see these round cells over here where I've drawn my green circle, and associated with them are these cells with a lot of cytoplasm flowing behind, okay, which you rightly called as ganglion cells. And Aradhana showed you the spindle cells. Okay, you don't see the spindle cells in the third picture. In fact, you see what is called this very pyloid background. It's made up of all these little hair-like processes that are present in the background. So now you tell me, anyone who is there, Amrita? We are seeing four pictures. At the beginning of the picture, you see the first picture, you're seeing nothing but round cells. Second picture, rosettes. Last picture, ganglion cells. And in between, you see something that is neither a ganglion cell nor is it a round cell. Okay, Amrita, so tell me, what is these four pictures actually about?
It's showing lots of differentiation from the first picture to the last picture.
It's showing lots of differentiation. So the first picture is very differentiated, and this last picture is not differentiated. Is that what you're saying, Amrita?
Yes, ma'am.
So this picture is not differentiated. Okay, and this picture that I'm showing you here is differentiated. Is that what you're saying, Amrita?
Yes, ma'am.
Does everybody agree with her? Lalit, you agree with her?
Yes, ma'am.
I see. What about Navneet?
No, ma'am. Actually, in first picture, all cells are round cells, and in last we can differentiate between the spindle cells and ganglion cells. So it is well differentiated, and first one is poorly differentiated.
So it's exactly the opposite of what Lalit and Amrita said. Okay, so here is where we get a clear picture. Now, what you are seeing is a differentiating neuroblastoma. The first picture is what we call an undifferentiated neuroblastoma. There is no differentiation seen. The second one is a poorly differentiated neuroblastoma. The third picture is a differentiating neuroblastoma. And on the right-hand side, this is becoming a ganglioneuroma. It is still not a fully fledged ganglioneuroma. It is a ganglioneuroblastoma. So three pictures of a tumor, which is a neuroblastoma. This is undifferentiated. The first picture that you see over here, let me get hold of a pen and of a different color now. So this picture that you see here is an undifferentiated neuroblastoma. There is no differentiation at all. Because what do neuroblasts, when they are going from their undifferentiated component right up till they become ganglion cells, or a ganglion cell is nothing but a neuron. Okay, so you have a neuroblastoma, or in other words, a neuroblast, which is going to become a neuron, and that neuron then gets associated with Schwann cells. Okay, so you have an undifferentiated neuroblastoma, and you have a poorly differentiated neuroblastoma. Okay, poorly differentiated neuroblastoma. Then you have a differentiating neuroblastoma, and then you have a ganglioneuroblastoma. Okay, so this is a picture from left to right. Has any of you, 8 or 9 people, how many do I have? 1, 2, 3, 4, 5, 6, 7, 8. Any of you seen a neuroblastoma in your lives? Have you seen one? Sneha, have you seen a neuroblastoma? You're a third year PT student. Have you seen a neuroblastoma?
No, ma'am.
No, ma'am. Okay, you come from Patna. You've never seen a
Yes,
pediatric case with a neuroblastoma. All right, let me ask Aishwarya at Muzaffarnagar. Have you ever seen a neuroblastoma?
Oh, ma'am.
No, ma'am. Deepak, you're from GMC Guwahati. Have you seen a neuroblastoma? Deepak, are you there or have you disappeared?
Yes, ma'am.
Have you seen a neuroblastoma?
Yes, ma'am.
You have. And what sort of neuroblastoma did you see, Deepak? You didn't see any of these phases in a neuroblastoma? Hmm? Okay, Amrita, you're from Ramaiya.
Yes, ma'am. Not.
Did you see? Have you seen a neuroblastoma?
No, ma'am.
Oh, Aradhna. Have you seen? Because you're from the same place as Deepak.
Yes, ma'am.
So if he's seen, you should have seen. Have you seen a neuroblastoma?
Yes, ma'am.
Yes. So now I don't know about Sakshi and Navneet and Lalit. Have you seen neuroblastomas? Lalit, have you seen?
Ma'am, ganglioneuroblastoma, not neuroblastoma.
That's right. You've seen a ganglioneuroblastoma. So at least here, I'm giving you all the hints. So here is differentiation that is being seen. You don't see all stages in all neuroblastomas. Sometimes you won't be seeing an undifferentiated neuroblastoma. The most common neuroblastoma that you see is the second picture, which is the rosetic neuroblastoma. And you see ganglioneuroblastoma and you see ganglioneuromas. And here is a neuroblastoma that has got this phyloid matrix, and it's not a matrix, it's actually the cell processes. And you see differentiating, the neuroblasts are differentiating and ultimately will become ganglion cells. Okay, so this is a matter of putting all these pictures together and trying to make some kind of sense out of what is being seen. Are there any questions in the chat box? I know lots of people answered because I could see them.
Yes, ma'am.
One
They are answering.
question.
They asked, can metamorphosis can be called differentiation? That was one.
Metamorphosis. Metamorphosis is changing from one life form to another life form. Okay, which looks completely different. In a minute, I will show you metamorphosis. Okay, it is a form of differentiation if it is the same life form. But if I turn into a lizard, then I have metamorphosed into a lizard, but I haven't differentiated into a lizard. Now you might ask, how can you become a lizard? I can't become a lizard, but in literature and in so many other forms of art and music and literature and plays and so on, people transform. No? Somebody becomes a crow or somebody becomes something else. Sorry, somebody said something. Yes, becomes a what?
Nagin.
Ah, okay. So that is a general term for changing one's life form into another life form. So metamorphosis. Meta is a transition from one thing to another. Metaplasia. It's a transition from one type of cell to another type of cell, and plasia means growth. So one type of growth into another type of growth. So you have squamous metaplasia from a glandular type of tissue to a squamous type of tissue. That is what meta means. Okay, it's a transition. So metamorphosis means one morphological state into another morphological state. So almost anything is that, and differentiation may be part of metamorphosis. So whoever asked that question it's an interesting.
It's mentioned as yum yum.
Yeah. Whoever it is, it's yum yum. Okay. All right. So get this now. We are talking about differentiation. I thought that I've got so few slides and we'll finish in no time at all. But we're stuck on the first slide itself, and that is what is differentiation. Okay. Let's go to. I have to get rid of this annotation. Stop annotation. Okay, come on. All right, and see, this is the fully mature form, which is a ganglioneuroma. An S100 protein has been done on this case because the neuroma part should be Schwannian, and therefore it should express S100 protein. Okay, so this is the most differentiated part of what is happening in a tumor. Neuroblastomas do this by themselves. That means they don't require over a long period of time a neuroblastoma, if it hasn't killed the patient, will become a ganglioneuron. Okay, and this happens under differentiating principles that are present in the body. All right, but if you start treating a patient with a neuroblastoma, sometimes you end up with a ganglioneuron. Okay, so let us now ask, how does differentiation occur? Who wants to take that question? Yeah, Navneet, you want to take the question? How does differentiation occur? And I'll ask you this. You see there's a caterpillar here? Everybody sees the caterpillar? And then there is this butterfly. Of course, this butterfly hasn't come from this caterpillar. Obviously not, because, and why not? Why not? Let's ask Aishwarya. This butterfly could not have come from this caterpillar. Why? It's just sitting on that caterpillar.
Caterpillar is still existing.
I know it's still existing, but you know that butterfly has come from.
It would have changed into a butterfly.
Oh yes, it would have changed into
Butterfly.
Butterfly.
It would have changed into a butterfly, but how does it become a butterfly? Huh? What happens? Now metaplasia. It metamorphoses. Yes,
Metamorphosis.
Yes, it does. And will any one of you answer, Deepak? It was your voice that I was hearing. Yes, Deepak. Can you tell me whether the genome of the caterpillar is the same as that of the butterfly, which arises from the caterpillar, or has it a different genome? Huh, Deepak? Yes or no?
It will be same. Yes, ma'am.
It is the same. Okay. So then, what is this process by which the caterpillar becomes the butterfly? Huh? We said metamorphosis, but what is it? It's differentiation.
Differentiation. Yes, ma'am.
It is. It's the same genome, but they're all cells of the butterfly. It's got the same genome as the caterpillar, and yet the butterfly has got wings. The caterpillar does not have wings. Does it or does it not? It doesn't, right?
Yes.
And that caterpillar will then become a pupa. From the pupa, that pupa will become an imago, and that imago will become a butterfly. And that is a process of differentiation. It is the same process as you will see over here. We have all of the cells that you're seeing on the right side, which is in a blood smear, right? Do all of those cells have all of them have the same genome? Lalit?
Yes, ma'am.
Does the basophil have the same genome as a monocyte, as a neutrophil, as a lymphocyte, as an eosinophil? Does every one of these blood cells have the same genome?
Yes, ma'am. They are the from the common myeloid progenitors.
Common myeloid progenitor. Okay. And the common myeloid progenitor has got the same genome as the common erythroid progenitor? Lalit?
No, ma'am.
Yes,
Different.
ma'am.
It has a different genome. Lalit, you say it has a different genome. All right. Somebody said yes, ma'am. Who said yes, ma'am? It has the same genome. Who said?
Ma'am, me.
Who's a me? Sneha.
Yes, ma'am.
So now Sneha, please tell Lalit why you said that the common progenitor of the myeloid series has the same genome as the common progenitor of the erythroid series, because he has a different opinion. You said it has the same, right? Will you
Ma'am,
please
every
tell-
cell of it, ma'am. Every cell arises from stem cell, so it has
so
same.
every cell in your body and my body, yes, has the same genome as we inherited from our zygote. Yes or no?
Yes, ma'am.
Yes, ma'am.
So now come on, Lalit. Why did you say that the genome? Do you know what is the meaning of the genome, Lalit? What's the genome? What did you understand by genome? Or you don't understand what a genome is? Do you?
No, ma'am.
Lalit, you are third year PG. You don't know what is a genome. Come on, Lalit. You know what is the genome. Don't get confused. Come on. What is the genome? Has it got anything to do with genes? Has it got anything to do what is there in the nucleus of a cell, a genome? Lalit, you have to think hard. Okay, let's ask the opinions. Or that Aishwarya, what is the
Yes,
genome?
Ma'am, it's the genetic makeup of an individual at the
Absolutely.
chromosomal level.
At the chromosomal level, it's at the DNA level. No, it's
Sorry, DNA.
Yes, it is at your DNA level. It's about your genes and all the stuff that is in between your genes, in your DNA. Okay, we have inherited half our genome from our father and half our genome from our mother, and then it gets pulled together, and you become you. Okay, so now will you tell? Do you know, Aishwarya, whether every cell in your body, whether it is myeloid or erythroid or liver or lung or skin, does it have the same genome?
Yes, ma'am.
Very good, Aishwarya. Deepak, what do you think?
Yes, ma'am. Same genome.
You think so? Amrita, what do you think?
Same genome, ma'am.
Same genome. Okay, Aradhana.
Yes, ma'am. Same.
Yeah, Aradhana, what are you saying? I can't hear you.
Same genome.
Same genome?
Yes, ma'am.
Yes, ma'am. You're saying it very softly. I think secretly you agree with Lalit. Huh? No, ma'am. All right.
Yes, ma'am. We said the same genome.
Same genome. Navneet.
Yes, ma'am.
Now,
Same
Lalit,
genome.
what was your problem? No, you have
Ma'am,
to solve that
yes,
problem, Lalit. So what is it?
Ma'am, genome, ma'am.
Same genome. So you cannot tell me that the myeloid genome is different from the erythroid genome and is different from the megakaryocytic genome. Huh, Lalit?
No, ma'am. I misunderstood.
Yeah, so you got it right. You knew it. It's just that you,
Yes,
for
ma'am.
some reason, you were confused. Okay? So there's no confusion now. Yes?
Yes,
We
ma'am.
all have. So now, Lalit, every cell in the body has the same genome. So why does the myeloid series look different from the erythroid series, and it looks different from the megakaryocytic series, and it looks different from the liver and the skin and the eye and the everything? Huh? So why does it look like? Why is it same genome? So how come my skin doesn't look like my liver, doesn't look like my RBCs? Yes, come on, Lalit. Same genome
Ma'am,
now.
different because of differentiation.
Yeah. So that's why I'm asking you. Yes, it is differentiation. So how does it occur?
By okay.
The same genome become different things. Lalit, did you ever think about it?
Ma'am, all the,
How does a caterpillar become a butterfly when it has the same genome as that of the butterfly? People are saying all sorts of things. Colony, differentiating factors, somebody saying differentiation. I'm asking you that. Okay, how does differentiation occur? We all have the same genes in every single cell. All right, but the liver is not doing what the skin does. Erythroid cells are not doing what myeloid cells do. The intestinal cells are completely different. One is columnar, the other something is cuboidal, something is round, something has a small nucleus, something has a large nucleus. So how does it happen, Lalit? And this is important because that's how we are able to know about differentiation in tumors. If we understand normal differentiation, we will understand
Different parts of genes get activated in different cells.
some different genes get activated in different cells. Very good. Who said that? Who said that?
Ma'am, Sneha.
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 Okay. Right. So how does it get activated? Do you think it's about activation alone or something else?
Ma'am, action of different markers on the cells.
I know that is what differentiation is about. So how does it occur? Well, does anybody know anything about a science or at least a part or a discipline that is called epigenetics? Okay, which means it is above the genome. Okay, so now we have somebody called Rupinder Kaur, and what Rupinder Kaur is saying, she's saying that there is a different sets of genes are activated and other genes are repressed. So it's about switching on and switching off the appropriate genes at the appropriate time in different cells, starting right from your zygote. What becomes the head, what becomes the tail, what becomes the skin, what becomes the liver from one set of genes. Okay, so it is the switching on and switching off appropriate genes at the appropriate time, depending on what, depending upon signals that cells get from other cells. They're exchanging talk all the time. Okay, and from the microenvironment. It's too big a subject for me to discuss, but when we are doing biology, we are now doing pathology, we are constantly looking at well and poorly differentiated tumors and tissues. Somewhere the thought should have come to us, how does all this differentiation occur? We're looking at blood smears, we're looking at bone marrows, and we see so many different kinds of cells and tissues. So if you're interested, please go and think about and read about epigenetics. Okay, so this is about switching on and switching off genes. Now, if your genes are abnormal as well, then the question of switching on and switching off can also be misdirected. Okay, so differentiation is an abnormal in neoplasia because of either genetic or epigenetic aberrations. It's not all, as you have all believed, that it is about mutations or gene rearrangements. No, it is a lot of what goes on in neoplasia is about epigenetic mechanisms and aberrations. And I just please go and read about how genes are switched on and how genes are switched off. Okay, there is a whole science of methylation and histone and protein remodeling, etc. Okay, so please go and do it. This is how differentiation actually occurs. Very good. It's like every cell has got the complete recipe book to do all kinds of cuisines, right? From Chinese to Indian to South American to American, to make burgers, to make everything. It's all in our cells. And yet, one part of the body just wants to do Chinese cuisine. The other one just wants to do burgers. The third one wants to do something else. So what do? Okay, that particular kitchen will highlight the Chinese and put some masking tape or in some way scribble over the rest of the recipes so that nobody gets mixed up. And suddenly, a cell that is or a kitchen that is supposed to be Chinese will start producing pav bhaji, because we have in our each cell a complete recipe book. But you don't want pav bhaji to be produced in a Chinese restaurant. Okay, so you have to mask all of that. So that is how genes are switched off, and there are a whole lot of genes that are switched on. So the spotlight is put on that particular the recipes that the cells actually require. All right, very good. Now, differentiation in neoplasia. Okay, all tumors, and please, I'm saying this again, benign or malignant. It is part of the definition of what is neoplasia. You may not find it written in your textbooks, but it is implicit in the definition that all tumors will show disorganized differentiation. Okay, and the benign ones are usually highly differentiated, but there is no guarantee that they will show you the differentiation that you think that they should show. Now, everybody was saying, starting with Lalit in the beginning, that tumors show differentiation towards their normal counterparts. Now, Lalit, here I have shown you there is a superficial parotidectomy that has been done in an adult. I think you should be able to identify this tumor, Lalit. Come on, Lalit. What is it? This is a tumor in an adult parotid, and you can see there is chondroid, there is mixochondroid, there is glands. Yes. So, Lalit, what is this? Are you there, Lalit?
It's a pleomorphic adenoma.
Adenoma. Is it a benign tumor or a malignant tumor?
It's benign.
Benign tumor. Now, you just told me, that differentiation with benign tumors look very much like their normal counterpart. What normal counterpart does this look like, Lalit? Anything in the salivary gland that looks like this? You've seen salivary glands, Lalit? Yes, you have, right? You've seen salivary glands with chondroid in it? Normal salivary glands? Lalit, just answer yes or no. Have you seen cartilage in a normal salivary gland? Huh? What's wrong with Lalit? The answer is yes or no. Come on. Why are you getting confused?
No cartilage in the salivary gland.
There is no cartilage. Okay, and here is a benign salivary gland tumor. Okay, so it's producing cartilage, it produces bone, it produces hyaline, it's got all sorts of cells. So I'm just trying to get you people to understand that you keep on with this mantra that differentiation in tumors and it looks like its normal counterparts. This is absolutely benign, Lalit. You've put off your video, but yet there is no benign counterpart that looks like this, does it? No, and yet this is a benign tumor. So please understand something, that whether a tumor is benign or malignant, all of them will show you disorganized differentiation, including a lipoma. Okay, a lipoma does not grow like normal fat, otherwise it wouldn't produce a lump. So benign tumors are usually highly differentiated. So a lipoma is a benign tumor and it looks very much like fat. But please remember that implicit in the definition of neoplasia is that all tumors show you a degree of disorganized differentiation. Okay, it's got nothing to do with whether something is benign or malignant. All right, let's also look at malignant tumors. Okay, malignant tumors vary in their differentiation. Some of them can be very well differentiated, and others can be less well differentiated to poorly differentiated. All right. So now, Navneet, your second year, tell me what tumor are we looking at here? What's the tumor on the left-hand side and what's the tumor on the right-hand side?
On the right side, we can see squamous cell carcinoma with keratin lesions.
All right, very good. So it's an invasive squamous carcinoma. Yes, and you would say that it's producing keratin. It's got good saturation. Yes, and keratin pearls. You're absolutely right, Sneha. So this is well differentiated. Now on the right hand side is what do you think, Navneet?
Poorly differentiated as
it's a carcinoma. And honestly, if somebody didn't show or didn't tell you that this was arising from the buccal mucosa and this is not glandular, and the most common tumor that arises from the buccal mucosa and which is not glandular is a squamous carcinoma. So you would know that this is a poorly differentiated squamous carcinoma, and it has certain characteristics. So number one, it is not showing you a keratin. Yes, it is also very disorganized in the way that it is infiltrating. It's not forming nice little nests over there. So its capacity to invade is also more evident than what you see on the left-hand side, which is malignant, yes, but it is a better differentiated tumor. And it is probably not going to produce as much destruction of the tissue through which it is infiltrating as a poorly differentiated tumor. So you get this, you get the message. So you have well, you have poorly, and in between, you have moderately well or moderately differentiated tumors. Now, people often think of invasive tumors as being well, moderately, and poorly. Do you realize that our in situ carcinomas and dysplasias also show you progressive lack of differentiation, albeit that it is still only limited to the mucosa? Okay, let me see if I can get hold of pointer. Yes, laser. Right. So just read my definition here. Okay, dysplasia. This means disorderly. Plasia is growth or proliferation. And in dysplasia, there is no invasion in any of these pictures that I have seen here, shown you here. But there is progressive lack of differentiation in these epithelia. Okay, you can have it in squamous epithelia, you can have it in glandular epithelia, but dysplasia is essentially this. You see here on the right-hand side of the top picture. Okay, you can see the basal layer. There is some abnormality. There's atyp here. The basal layer should be the one that shows this nice basal palisading. Above that, there should be no palisading. No, all the nuclei should start now to be horizontal. But you notice that they are no longer horizontal. They also look somewhat like what the basal cells look like. You notice that you see the basal cells, and these cells above in the parabasal and low intermediates are looking like basal cells. So what does that tell you? Basal cells should differentiate as they go up. They become flat. They become their nuclear characteristic change, and here it is not. So there is progressive loss of differentiation. But towards the top, there is better differentiation. Okay, so this one seems to be probably moderately differentiated. Okay, now you see here on the left hand side, you see that all of the cells now above this basal layer are beginning to look quite a lot like basal cells. They're no longer flattening out like they should be. So this is moderately differentiated. This is now becoming poorly differentiated. But we don't use those terms. And see what you see down here. Both are extremely poorly differentiated because all of them now have lost their characters of as they should differentiate towards the top. In this happens to be the cervix, but it could be any squamous epithelium. So, but we don't use the terms well, moderately, and poorly differentiated for dysplasia. We use those terms, or we reserve those terms for invasive carcinomas. But when it is limited to the epithelium, you do get low, moderate, and poor differentiation. Yeah, in these things, but we call them. There are all kinds of terms that we use. We call them dysplasia, low-grade dysplasia, intermediate-grade dysplasia, and high-grade dysplasia. We don't use the term well, moderately, and poorly. So we grade them for architectural disorganization, atypical cytomorphology, and abnormalities of differentiation. Okay? And we call carcinoma in situ when there's complete lack of differentiation, like what you see towards the bottom right-hand side picture. Although if you really think about it, it is well, moderately, and poorly differentiated without any invasion. So what terminology do we use? We call them intraepithelial neoplasia, grade 1, 2, 3. If it's in the endometrium, we call it EIN or EIC and whatever, ADH, DCIS. There are all kinds of names that we give to this kind of in situ change, and we grade them according to 1, 2, 3 or whatever else that we want to use. Okay, but remember, dysplasia is also progressive lack of differentiation in an epithelium where there is no invasion. The moment this thing invades, then you can use the terms well, moderately, or poorly. Is there any question about this? If there's any question, I'm happy to repeat this. Any question in the chat box?
No questions.
No question. Thank you. All right. So now we've gone on and on about differentiation. Will anybody tell me why is differentiation important? Why are we bothered so much about differentiation? Amrita, will you tell me why is differentiation important?
Well, it's required for the cell function and cell
Yes,
function.
that is true, of course, under normal conditions. But now we have to move from normal conditions to neoplasia, right? And we've now started talking about tumors because today's talk is about poorly differentiated tumors. So why is it important for us to know about differentiation in tumors?
It tells the cell of origin and
It tells the cell of origin. Okay, very good.
And
That's very good. I think both Sneha and Amrita said that. Anything else? It tells the prognosis. Okay, very good. Who said that? Deepak? Okay, Aishwarya, anything else?
Treatment. Different tumors have different treatment and targeted therapy.
So it's important for us to understand this because it has a bearing on clinical practice. Okay, so what you guys said is very good. So now you've understood that lineage, or what we call histogenesis, is discernible, and therefore a diagnostic or a histogenetic label is more easily assigned. If I can see glands, if I can see squamous epithelium, if I can see melanin or something else, then I know what kind of diagnostic label is to be assigned. Okay, and for years and years and years, we have been trained as morphologists to do this. Find that histogenesis of a tumor. Okay, it's becoming more and more. Sometimes people feel that histogenesis is no longer very important as far as management is concerned, but we leave that to another day. This is it allows you to use the histogenetic label if you are able to see some kind of differentiation. And as you rightly said, or some of you, it has prognostic and therapeutic significance. As far as is possible, there are some tumors that respond better to certain kinds of tumors that respond better to certain kinds of therapies than others. A well-differentiated tumor may have a better prognosis, but it may not respond as well to the same kind of therapy that a poorly differentiated tumor will respond. Like for instance, chemotherapy. If you've got a very well differentiated tumor, the growth rate or the turnover in that tumor is so low that if you're going to use chemotherapy that it affects the cell cycle, it's not going to really make much of a difference because that cell is not cycling. Okay, but if there is a poorly differentiated tumor which has got a higher cell cycle, which we will talk about in the next point or so, then of course it makes a lot of difference that you can use some chemotherapeutic agents which will slow the growth of that particular tumor. So there I have mentioned it. Better differentiated tumors are generally better behave. Generally, okay. Nobody says that all better differentiated tumors will behave very well. Quite often it is dependent upon how far they have spread. So if you've got a well differentiated tumor but it is spread, you're not going to really get the same result as a well differentiated tumor that is still limited to the organ. So it's about differentiation or grade as well as stage. So we can't generalize. The better differentiated tumors are usually less proliferative, and I told you what are the consequences of that for treatment. And they're more often amenable to loco-regional therapy. That means, surgery with removal of lymph nodes, and sometimes with the addition of adjuvant radiation therapy. And they're less responsive to what we call anti-mitotic therapy, which tries to cut down the proliferating tumor burden in that particular patient. Okay. Now, we also often do grading based on differentiation. We say, well, moderately, poorly differentiated. And in many organs, well differentiated is grade 1, some moderately differentiated is grade 2, and poorly differentiated is grade 3. We also talk about, I've said that, grade 1 to 3. Sometimes in some organs, we actually have 4. And in some organs, we have just a binary thing, low grade and high grade, like we're now doing in urothelial tumors. So this is why differentiation is important. Okay, so now let's come to poorly differentiated tumors. What is a poorly differentiated tumor? And the first line that I've written over here is important. It is a term that is very ambiguously used. And it is often includes what otherwise we would call undifferentiated tumors. A poorly differentiated tumor, if you think about it, there is differentiation, but like the poorly differentiated squamous carcinoma, I can make out that it is squamous, but the differentiation is very poor. It is not showing you keratin, etc. Now that's the correct way in which the term poorly differentiated tumor should be used. But in our usual way in which we write our reports, we teach our students, we even think, is that this term poorly differentiated often includes undifferentiated tumors. Okay, we'll come to that. It's also used for something that is undefined on histology. And you know what I mean by undefined? I look at it, and from the morphology, I cannot tell whether this is a carcinoma, this is a sarcoma, this is a lymphoma, this is a melanoma, it is some other undifferentiated tumor, some blue cell tumor. When I don't know what something is, and I cannot see any differentiation, before I start to do immunohistochemistry or anything else, I use this term. I am looking at a poorly differentiated tumor. It's not a good term to use, but that is a term, unfortunately, that is there. It's in your textbooks, it is in articles, in the way that we think. So often, you see I put this in bold. Tumor with poor or no discernible differentiation on morphology, which means H and E. So that is what we often refer to as poorly differentiated tumors. It should not be the strict definition. The strict definition I put down in red at the bottom, but this is what we call poorly differentiated in our everyday use of the term. Ancillary techniques like immunohistochemistry, molecular, and other things may be required to determine the tumor type in this ambiguous diagnostic situation. Ambiguous means where we are unable to make a concrete diagnosis, and before we assign a grade. Okay, sometimes we come to a conclusion that this is something before we actually assign a grade. Now, this is particularly so at sites such as the lymph node, liver, and lung. Okay, so if you want to be a purist, then the term poorly differentiated should be restricted to those tumors where differentiation can be assigned on morphology or on immunohistochemistry, but where that differentiation is very poor or is minimal. That is truly a poorly differentiated tumor. But as I said, we in everyday parlance and everyday talk, we often use it for this tumor with poor or no discernible differentiation on morphology, and then we go on to do various other tests. So come on now, somebody's going to tell me what we have over here. All right, Aradhana, you want to take this? This is a biopsy from the cervix of a post-menopausal female. I'm not asking you to make a diagnosis. That's not the purpose of this thing. Just tell me what you are seeing in these slides. Okay, obviously it's one case because it's a biopsy. What do you think? Do you think that this is poorly differentiated? If it is so, what is the differentiation that you are seeing? And if you can't see any differentiation, then tell me how do we go about it? Is this poorly differentiated? Number one.
No, ma'am.
Okay, so you can see differentiation. All right, you can. Can you see differentiation? Who's answering? Sakshi?
Signet rings.
Sorry?
Signet rings.
Signet rings. All right, come on now. Ask for annotation and please show me where are these signet rings. Where are the signet rings? I see lots of things. Vague, adeno, somebody saying rhabdoid. Yeah, come on, Sakshi, where are the signet rings?
I didn't say signet rings.
Oh, you did. Who said it? Aradhana?
No, ma'am.
Then?
Ma'am, I said signet ring.
Yeah, so come on then, show me. Ask me. Ask for annotation.
Ma'am,
What? Because I don't
I'm
see
showing.
You're showing the signet rings. Where? Where? Have you asked for annotation?
I have marked. Ma'am, I have marked it.
You are marked. Oh, there. You are marked over there. Okay. So that's your annotation over here. So you think that is signet ring. Everybody agrees with Sneha that this is signet ring? Come on, Lalit. Do you agree that this is signet ring? Lalit, are you there? Lalit has disappeared. Deepak, is this a signet ring?
No, ma'am.
No. Why is it not a signet? If you say no, you have to tell her why it's not signet ring.
No, it looks more like a squamous cell, but it's poorly
It looks more like a
differentiated.
squamous cell. Why is it a squamous cell? Why is it a squamous cell? Can you describe the cell, please, Deepak? Please describe that cell. Come on, Deepak. You said it was squamous.
Cells.
So please describe the cell.
Eosinophilic cytoplasm with hyperchromatic nuclei.
What? There is eosinophilic cytoplasm. Very good. Then?
Yes, ma'am. And hyperchromatic.
Hyperchromatic nucleus. Yes. So that makes it a squamous cell. Why is it a squamous cell? So anything. Everybody's just allowing anything, calling it a squamous cell. So your differentiation says that it is a squamous cell. Somebody is saying that it is rhabdoid. Somebody is saying that it is signet ring. Anybody has got somebody said adeno. I don't see any adeno over here. What I see is that there are cells, okay, which are in nests, and I can see these nests very clearly. Can I see nests or I don't see nests?
Yes,
Of course I see nests. I see nests, large and small, and these nests are composed of cells which have Yes, cytoplasm, eccentric nuclei. Of course, the nuclei are eccentric, and these eccentric nuclei have actually got some kind of shape. No, the shape is like you would call it a crescentic shape, but all of them are not crescentic. The ones that you were showing me were showing crescentic. Many of them are round, but there is a good deal of anisonucleosis. Okay, so I got all that I have to help me over here is that there are nests. Okay, and the nest suggests to me that this is unlikely to be a sarcoma. Do you agree? Huh? You see nests in a sarcoma? Come on, ask. As Navneet, you've seen enough pathology. Do you think you get nests in a sarcoma?
No.
No. So when you see nests, what does nests tell you? What does nests tell you?
Epithelioid region of
Very good. That this has likely to have some. In fact, this looks like an a category of tumors that have an epithelioid appearance. Okay, that is something that is very evident from this. So my mind is saying this is cervix, postmenopausal woman. Things are in nests. This is obviously not got any differentiation towards squamous, and I know why they said squamous because it's a cervix. Okay, and it's got cytoplasm. Okay, but I don't think that we can call this a squamous carcinoma. So it could be some form of carcinoma that's in the cervix, but it could be something else also. So what are the other things that are in nests? Anything else grows as nests?
Basal cell carcinoma.
Huh?
Basal cell carcinoma. Basal cell carcinoma.
Yeah, in the cervix, right? See how? What grows as nests that might occur in the cervix? So now don't talk about basal cell carcinoma because it doesn't occur in the cervix. Okay, so it is some form of carcinoma. Very good. What else? Somebody in the chat box is saying neuroendocrine carcinoma. Very good. Yes, neuroendocrine carcinoma might, and they may have a plasmacytoid appearance. Excellent. And what else? Somebody called Sachina says small cell carcinoma. Yeah, perhaps there's too much cytoplasm for the usual small cell carcinoma. Anything else? What else? Somebody saying rhabdomyosarcoma. Possible, but in a postmenopausal woman, I would be a little bit. Somebody said rhabdoid tumor. Yes, but this can also be a melanoma, right? That also grows as nests. Now, somebody called Anam is saying choriocarcinoma. I think that would be a little odd for a postmenopausal woman, and it doesn't really grow as nests. Okay, so this, in other words, when this comes onto your desk, you can't see any characteristic differentiation. It has got no keratin, it has no melanin, it has no feature of no mucin, no glandular. All that I know is that it is epithelioid, and it could be neuroendocrine, it could be some form of carcinoma, it could be a melanoma, and I have to find out what it is. This is the usual kind of tumor that people refer to as poorly differentiated tumor. Okay, it is not strictly a poorly differentiated tumor because you can see absolutely no differentiation over here. So we now have to see, is this a poorly differentiated carcinoma? Is it a poorly differentiated neuroendocrine tumor? Or is it a melanoma? Okay, so now let us see what it turned out to be. Okay. Oh, I have to get rid of my annotation business, otherwise I can't move. So now, who is this now, Navneet? Tell me, what is it? I've given you some immunohistochemistry. Now, please let Navneet answer. All right, this is the cervix. You see here that this is the squamous epithelium of the cervix, which has taken up pancytokeratin. And here is the tumor. Is the tumor positive or negative, Navneet?
I'm positive. No, I'm negative. It's negative.
Negative. Excellent. Very good. Now, here is S100 protein. Is this tumor positive or negative?
Positive.
Positive. And here we have melan A. Is it positive or negative?
Positive.
Right. So, what's the diagnosis, Navneet?
Melanoma.
Right. So, this is a melanoma of the cervix. We started off by calling this a poorly differentiated tumor because we didn't know what it was. So it was an undefined tumor when it arrived on our desk on the H&E. But now that I know that this is a mucosal melanoma, Navneet, am I going to call this a poorly differentiated mucosal melanoma? Go on, Navneet.
Only after IHC that
I got the
we
IHC.
can
Now we know it's a melanoma. So in my report, am I going to call this a poorly differentiated mucosal melanoma? All right. Let's go to Sakshi. Sakshi.
Yes, ma'am.
Tell me, am I going to call this? I call this a poorly differentiated malignant tumor when I did not have the immunohistochemistry because I didn't know what it was. It was an undefined tumor. Okay, and a lot of us call these things poorly differentiated malignant tumor on an H&E until we get our immunohistochemistry or molecular or special stains or whatever. Now we know it's a mucosal melanoma because we got the immunohistochemistry. So now you tell me.
Yes, ma'am. Now we can give the report as poorly differentiated melanoma.
So now you give the report as poorly differentiated mucosal melanoma. That is what Sakshi would do. Okay, Aradhana, what would you do?
Poorly differentiated.
Poorly differentiated mucosal melanoma. That's what you would call it. Yes.
No,
Yes. No, ma'am.
negative.
Huh?
What
What would you call it? I can't hear you. Aradhana, what would you call it?
poorly differentiated malignant melanoma.
Poorly differentiated malignant melanoma. Okay, so you're going to call it a poorly differentiated melanoma. All right, very good. Amrita, what would you call it?
Poorly differentiated mucosal melanoma.
Very good. Aishwarya? Aishwarya? What? Huh? Aishwarya, are you there? Aishwarya from Muzaffarnagar has disappeared. Sneha?
Ma'am, I'll write as mucosal melanoma.
You'll only write mucosal melanoma. Why? And not, they are saying poorly differentiated malignant melanoma. Why are you only going to write mucosal melanoma and not say poorly differentiated? Why?
Since IHC is positive, that means
I know it's a
there is
melanoma.
antigen.
Oh, very good. I know it's a melanoma, but they want to add the term poorly differentiated malignant melanoma. You don't want to call it poorly differentiated. Why? So you don't know. Deepak?
Yes, ma'am.
Yes. What would you call this? Poorly differentiated malignant melanoma or just malignant melanoma?
Poorly differentiated malignant melanoma.
Poorly differentiated malignant melanoma. All right. Lalit, are you there?
Yes.
What would you want to call it, Lalit?
Then
All right, Lalit. So please explain to the rest of them who are all wanting to call it poorly differentiated malignant melanoma. Why would you not call this a poorly differentiated malignant melanoma and just say malignant melanoma or melanoma, whatever?
it on the immunohistochemistry. So
I know that it is a melanoma, Lalit, but why do you not want to add the term poorly differentiated to it? Huh? In your report, you write poorly differentiated malignant melanoma. Why aren't you going to do that, Lalit?
Ma'am, no differentiation in melanoma.
So Lalit, the answer is to Sneha. The answer is there are no well differentiated melanomas. All right, we never talk about well, moderately, poorly. Do we say grade 1 melanoma and grade 3 melanoma? No, the word malignant melanoma is a diagnosis. Sorry, the term malignant melanoma is a diagnosis. And we don't have well and poorly. No, we have spindle cell, we have balloon cell, we have different kinds of morphologies in a melanoma. This is one morphology which looks plasmacytoid, okay? But we do have things like well, moderately, poorly, etc. So do you guys get the point that the differentiation in some tumors can be put as well, moderately, poorly? We have seen that. We have seen that in neuroblastoma. We have seen that in squamous carcinoma. We do it in adenocarcinomas. We do it in many tumors. But there are some tumors where the diagnosis cannot be qualified by well, moderately, poorly. Not even as grade 1, grade 2, grade 3. Not even as high grade and low grade. And melanoma is one of them. Have you got the point? Are there any questions? Any questions in the chat box?
Ma'am, Anupati asked undifferentiated and poorly differentiated for interchangeable terms.
Yes, we'll come to that in a minute, but we're talking about melanoma. Okay.
Okay, no questions.
Right. Yeah. Let's go to we're just now elucidating many things. So this tumor started out on H&E by being labeled as a poorly differentiated malignant tumor. We did not know that it was a melanoma. We did not know what it was. Okay, we had guesses, but we did not know what it was until we did immunohistochemistry and found out that it was a melanoma. And Lalit is absolutely right. There are no different differentiations in a melanoma. There are morphological types of melanomas, but there is no well, moderately, poorly grades in a melanoma. So if there are no questions on this, then we will go to the next thing. But please understand that it started as a poorly differentiated malignant tumor, turned out on immunohistochemistry to be a melanoma, and then we don't have to talk about this being poorly differentiated anymore. Now let me ask the other question. Lalit, you were very right on this. Suppose this had turned out to be a carcinoma. So suppose it turned out to be a squamous carcinoma, that it was pan-CK positive, it was P63 positive. What would you have called? What would you call this? So now you have to give a diagnosis. It is a squamous carcinoma. So now what would you call it? This was the original tumor, and now we have found out by doing immunohistochemistry that it is a squamous carcinoma. Okay.
Poorly differentiated HCC.
I see.
Yeah, so that's right. So we will use that term if it was a squamous carcinoma. If it turned out to be an adenocarcinoma, we would say poorly differentiated adenocarcinoma.
Adenocarcinoma.
But we cannot call it a poorly differentiated melanoma. This tumor started out as being a poorly differentiated malignant tumor. Depending on what we discovered when we investigated it, you use that term poorly differentiated again, or you don't, as the case may be. Okay. Now here we have another case. Now who wants to take that? Sneha, come on. Sneha, biopsy from the nose of an adult patient. What do you see over here? What will you say on H&E? And then we will proceed. What are you seeing? No, we're talking about poorly differentiated tumor, so you have to tell me now. Does this qualify for being a poorly differentiated malignant tumor? First of all, you think it's malignant? Sneha?
Yes, ma'am.
Very good.
Yes,
So
ma'am.
now, does this qualify for a poorly differentiated malignant tumor? Do you see any differentiation in this at all?
No, ma'am.
No. So, in layman's term, in the way that we often think about it, what can we say that this is a tumor that is in sheets? Yes, you can see that it is in sheets.
Sheets.
There is no differentiation at all. There's a lot of necrosis, which you see in this middle.
Necrosis.
It is in sheets and it is round cell. Yes or no?
Yes,
So
ma'am.
it is in sheets and it is round cell. And it lands on your desk and you see this H&E. And what do you want to say that I got on my table, on my microscope side? A round, poorly differentiated malignant tumor with a round cell morphology. Okay? And we're using this term poorly differentiated to mean an undefined malignant tumor. And now we have to define it. And therefore we have to do immunohistochemistry. Yes? Correct. Okay. So we have to do immunohistochemistry. Now I'll show you what is the immunohistochemistry. Now come on, say how you're third year. And you can see all these things. You see all the immunohistochemistry.
Neuroendocrine tumor.
It's a neuroendocrine tumor. Please look at what we have done. Okay, CK EMA is it
Oh, sorry,
positive?
negative.
Oh, very good.
Negative.
Then how can you call it a neuroendocrine tumor? All right. So it's CK or EMA, and we have to do our immunohistochemistry based on the differential diagnosis. One of the differential diagnoses is it's a very poorly differentiated neuroendocrine tumor. It could be a lymphoma. It could be it could be some kind of melanoma. It could be an olfactory neuroblastoma. It could be many things. Okay. So now CK EMA. CK EMA is negative. Synaptochromo is negative. There is no CD20 because you can see CD20 is only in some background lymphocytes here and there. There's no CD3, no CD5 because the majority of the cells are negative. But there's a lot of CD2. Right?
NK cell, CD56.
There's a lot of CD56, yes. So you're getting the picture that it could be an NK cell tumor. And here you can see granzyme B, which is what NK cells express. But NK cells, if they're pure NK cells, should not show you CD2. No, it is a T cell marker. And here we have Epstein-Barr virus immunohistochemistry. So it's being expressed. EBAs are being expressed in the nuclei of the cell. So now what is it, Sneha? What is it? I've got NK, I've got T, I've got Epstein-Barr virus, I've got granzyme B, which is a cytotoxic marker that is being expressed by this tumor. So what's the diagnosis, Sneha? Or anybody else if they would like to answer? And it's in the nose, and this tumor is not expressing CD3 or CD5. It's not, of course, expressing CK or synaptochromo, no CD20. It couldn't express CD20 because it's CD2 positive. Come on, anybody? What are they saying in the chat box?
They're saying NK cell lymphoma, NK T cell
NK, no,
lymphoma.
it's a T NK, no, because there's T and there's NK in that. And then it's got Epstein-Barr virus. So what is that tumor that occurs in the nose? Huh? It's an EBV-associated non-Hodgkin's lymphoma of nasal NKT cell type. I don't want you to make a diagnosis, for God's sake. I'm just showing you what things that we come across, which we call poorly differentiated malignant tumor, and what after immunohistochemistry it gets turned into. Now, Sneha, yes, this is an EBV-associated non-Hodgkin's lymphoma. Are we going to use the term poorly differentiated non-Hodgkin's lymphoma, Sneha?
I don't know, ma'am.
You don't know. All right, Navneet?
No, ma'am.
No. Why Navneet?
No.
Because same story with Lalit.
Morphologically, it
Because
will be
there are no
more
such things as
outside.
poorly differentiated lymphomas. Okay, there are no poorly differentiated. You know any poorly differentiated lymphoma that we talk about? No, we talk about high grade, we talk about low grade, we talk about the different kinds of lymphomas, but we don't call anything a poorly differentiated lymphoma. So what is this particular case and the mucosal melanoma case? What is it saying to you? That tumors may start out by being poorly differentiated malignant tumors where we don't see differentiation. We are not able to actually make a diagnosis because we don't see either keratin or some squamous or some idea that this may be a carcinoma or this may be a sarcoma or anything at all. It's totally lacking any kind of differentiation, and so we use this very non-specific term for an undefined tumor on H&E, and we call it a poorly differentiated malignant tumor. But now, after we have proved, like we proved for the melanoma, and we have proved for this, that this is an EBV-associated nasal type NKT cell lymphoma, we can't use that term poorly differentiated in our diagnosis anymore. So these are two examples as to how poorly differentiated malignant tumors have been sorted out, and then we can't use the term poorly differentiated in our diagnosis anymore. Okay, so this is how we approach a tumor with poor differentiation on morphology. That's what we have been talking about in the last two cases. We need a good clinical history and localization. You need a good H&E because you have to look for subtle signs of differentiation. Okay, if you've got a biopsy, for you as postgraduate students, you never bother about this. But those who are in practice, if you've got a biopsy, please don't take ribbons. You know, ribbons are taken just like that. You know, beautiful arcs and in long rows. You know what is a ribbon? They just tuck and cut all the wax and put it on the the sections in wax and put it on the. Please don't do that because when you have poor differentiation, and there are some sites where you expect poor differentiation. In the nose, paranasal sinuses, sometimes lymph nodes, our needle core biopsy should never have ribbons, okay? Because you need material for immunohistochemistry, other ancillary tests. You must look at the overall pattern of growth, and we did that, where we saw the, the nice nests in the previous thing, so that you can then direct your immunohistochemistry in a particular way. We must look carefully for signs of differentiation. Okay, we can't call everything poorly differentiated malignant tumor. Keratinization, melanin, large prominent nuclei, or any other signs of differentiation. And then, of course, you have to do immunohistochemistry or molecular techniques. Sometimes you may see some keratinization, some melanin, something or the other, but to prove that what you're seeing is not a figment of your own imagination, then you may have to do immunohistochemistry anyway. Okay. And what we have been describing so far is how do we classify patterns. Okay. And we classify patterns, which is very important for poorly differentiated tumors, into monomorphic or pleomorphic. Okay. Into those that look epithelial or epithelioid, and we saw an example, mesenchymal, bi, triphasic tumors, round cell, or hematolymphoid. And how do we define epithelioid? Anything that is epithelioid must be cohesive, they must hang together, it could be flat, cuboidal, or columnar cells. That's what we call epithelioid. If something doesn't hang together, it's not cohesive, it's not epithelioid. Mesenchymal, it's spindle, stellate cells, the loose arrangement. Sometimes you have matrix formation in that tumor. By triphasic tumors, it can be epithelial or epithelioid with some mesenchymal spindle or stellate cells, and sometimes round cells also mixed up in it. And they don't have to be malignant, they can be absolutely benign. And then you have the round cell hematolymphoid things where you have small blue cells with little cytoplasm which are prone to crushing, and they are really very difficult tumors. Okay, and bi and triphasic tumors do not usually come into this poorly differentiated category. It's this epithelioid, mesenchymal, and round cell or hematolymphoid. Yeah. Now here is what we call monomorphic. There's sheets and sheets. They don't have to be small. You can have sheets and sheets of large cells, all looking the same. Okay, then you call it a monomorphic tumor, like a hepatocellular carcinoma. It's not poorly differentiated, but that is what we call monomorphic. And this is what we call pleomorphic. There is marked variation. Pleomorphism is marked variation. So I hear students calling any and everything pleomorphic. Anisocytosis, anisonucleosis is not pleomorphism. Okay, right. So that's monomorphic, and that's marked variation. So that's pleomorphic. And you have some sub-patterns. Would anybody like to tell me what this pattern is on the left-hand side? Deepak, the left-hand side picture. What pattern is that?
Monomorphic.
Monomorphic. That is the major pattern, no? Monomorphic and pleomorphic. We have some sub-patterns now. What would you call this? I told you, you have monomorphic.
Screening pattern.
Then you have some sub-patterns, right? Epithelioid, mesenchymal. That's how we make diagnoses. If you're not doing it that way, then there is something that you need to introduce into your diagnostic armamentarium. Okay, so what is this sub-pattern?
It's a screening pattern.
Streaming pattern, that's not a pattern. We have epithelioid, we
epithelioid,
have we have bi or triphasic, and we have, so what is it?
Ma'am, first one is epithelioid. Second one
Okay,
is mesenchymal.
good.
Yes, ma'am.
The second one is
Mesenchymal.
very good, and the third one is
Round blue cells.
Small.
so small blue cell, so it's a round cell.
Round cell.
Yeah, so that is epithelioid. This is mesenchymal and infiltrative, so this happens to be a desmoid tumor. That's okay. This one is small blue cell. Now, would you like to tell me what this epithelioid band thing is? Would you call this a poorly differentiated malignant tumor? Come on, that's what we're here for today.
Ma'am, but there is no pleomorphism. It's a uniform, so we can't.
So what are you saying? Is this poorly differentiated or not poorly differentiated?
Not poorly differentiated.
Not poorly differentiated. Okay. So this is epithelial. So what do you think it is? What differentiation are you seeing in this tumor? Tell me. You said it is not poorly differentiated, right? So you have to tell me what differentiation are you seeing? It's not an undefined tumor, in other words. Okay. It's only H&E.
Yes, ma'am.
Yeah, we can do immunohistochemistry if you wish, but you tell me, if you are not saying that this is a poorly differentiated tumor, what differentiation are you seeing? Lalit, come on.
Uh,
Are you seeing any differentiation? Then why are you not calling this poorly differentiated?
uh,
That's a problem, isn't it?
Yes, ma'am.
But on the small blue cell tumor, do you have any problems?
No,
Is
ma'am.
that poorly differentiated? What? Is that poorly differentiated or not?
No, ma'am.
Oh, that is also not poorly differentiated for you. All right, let's ask your colleagues now. Navneet, will you pick out the poorly differentiated tumors in these three photographs?
Ma'am, first and third.
First and third. Okay, Navneet. Sakshi.
Ma'am, they all are poorly differentiated. We cannot type the tumor based on
So you think all of them are poorly differentiated? All right. So that's Sakshi. Aradhana.
all.
All are. Okay. Amrita.
All, ma'am. All the three.
All. Okay. Deepak.
Yeah, one and first and three.
First and third. Aishwarya.
Ma'am, I think just the first one is poorly differentiated.
Only the first one. Okay. And Sneha.
Ma'am, first one is poorly differentiated.
And the others are not poorly differentiated. Yeah.
Yes, ma'am.
I think that those who answer first and third are right. Because in the middle tumor, I can make out that these are fibroblasts, they're microfibroblasts. I don't have an issue with that. I know when I look at this, that this is so differentiated. You can see the tumor is making collagen, and this is a desmoid tumor. You may not be able to do it because you haven't seen desmoid tumors, but there's nothing poorly differentiated about that. Okay, it's a stat. It would be like saying I'm showing you a leiomyoma, and you say that it's poorly differentiated, or no, it cannot be. It's a smooth muscle tumor. It looks like a smooth muscle tumor. Okay, leiomyosarcoma, which you can't tell, but the middle tumor is differentiated. It's the two at the other end that are poorly differentiated. Okay, you don't see any kind of. And what do we mean by differentiation? Is there any sarcomatous differentiation? Meaning, do you know whether they are sarcomas or carcinomas? That also you can't tell. Can you tell whether they are, one on the right side, is it a lymphoma? Is it a carcinoma? Is it a melanoma? Is it a neuroendocrine tumor? No, because there is no differentiation that you can see. You need to go and do some immunohistochemistry or know where is the location of the site or some other thing to give you a clue as to what this is. You look at it and you don't know. Here on the left-hand side, you know that this is epithelioid. There is variation. You can see big nucleoli. There's variation in nucleus size, shape. There is an so it's not pleomorphic, but it is certainly not monomorphic in that sense of the word. Some of these cells are looking a little spindly here near the top. Some of them are looking more epithelioid over here. And honestly, I don't know what it is. But if I knew where it was, I might have a guess, but I really don't know what it is. And you know what that epithelioid tumor turned out to be? It was a gastrointestinal stoma tumor. Okay? We had to do immunohistochemistry to prove it. It was a retroperitoneal mass. And what was the small blue cell tumor? What did it turn out to be? It's a small cell carcinoma. Yes. But whatever you might do, it was only an educated guess. It was not a way that there was no differentiation. So once again, and please remember, see, a gastrointestinal stoma tumor is not a malignant tumor per se. So epithelioid gastrointestinal stoma tumors are not malignant. There is graded risk. So you may have, and what I want to point out to you over here, that something that might look poorly differentiated to you when you first look at it may turn out to be something that is not malignant. Then here it is, a gastrointestinal stromal tumor. On the other hand, of course, if you've got something like the small blue cell tumor, it is more often than not malignant, and it is a small cell carcinoma. So there are lessons to be learned that you cannot assume that when you see something that is poorly, what we call, as I told you, this is the terminology that we use, poorly differentiated tumor on H&E. Once you have done whatever immunos that you have to do, or molecular or anything else, you may come to a conclusion, A, that it is whether the term poorly differentiated should be used or not. Like if you find out it's squamous or adeno or neuroendocrine, you can use that term depending upon what that tumor turns out to be, well or poorly. Here, you can't use this term poorly differentiated gastrointestinal stoma tumor. In fact, it's for all practical purposes benign. And on the other hand, here, yes, it is a small cell carcinoma, but it has a name. If you want to call this a poorly differentiated neuroendocrine tumor, you are perfectly justified in calling it that, because poorly differentiated neuroendocrine tumor is a valid diagnosis. Now, are there any questions about this amongst you 8 over here or anywhere? Lalit, do you have a confusion? Because you didn't think that anything was poorly differentiated over here. Is your confusion clear, Lalit?
Yes, ma'am. Yes, ma'am. I'm
Do
clear.
you understand what I'm trying to say? Because I will ask you all of this at the end, okay?
Yes, ma'am.
So, because you cannot go away with any confusion, okay? Very good, Lalit. All right. So, what immunohistochemistry shall we do? And I don't think that you need to do this. Anyone wants to take a screenshot, do it. But you have to do appropriate immunohistochemistry, okay? If you think that something looks epithelioid, then you have to do the keratins, EMA, synaptochromo, P53, and so on. If you think, like we did, and I showed you some examples of what we had to do, as well as, if you've got a round cell tumor, what you will do. And today we have so much immunohistochemistry. We can do B-core, INI, and BRIG, and all sorts of things, which will tell you what tumor we are actually dealing with. All right, now here we are. Who wants to take this now? I don't know who. Deepak, you want to take this? Come on. This is an enlarged lymph node in the neck of a young adult. Please look at this, and you know that we're dealing with a it's a lecture on poorly differentiated tumors. Do you think that this is poorly differentiated? Deepak, have you gone to sleep? Come on, answer quickly. Do you think that this is poorly differentiated?
No, and it's not poorly differentiated.
It's not poorly differentiated. That's right. So what differentiation do you see? You understand what we mean when we use the term on morphology of H&E as poorly differentiated? Yes, what do we mean? Tumor with poor morphological differentiation. Now tell me. That means we can't see glands, keratin, pigment, anything that will tell you that what this tumor is. Yes, Deepak? Have you gone offline or what? Can you hear us? Okay, we can't hear you. All right, Deepak seems to have disappeared. Aishwarya.
Ma'am, I think the first picture is.
They are all the same. It's low power, medium power, high power. So now don't think that there are 3 different tumors. Come on, Aishwarya. Do you think that you can see some differentiation in this tumor? If you see some differentiation in the tumor, then you know what the tumor is. Do you know what it is? It's an enlarged lymph node in the neck of a young adult. Do you think it's a lymphoma? Do you think it's a carcinoma? Do you think it's a sarcoma? Do you think it's a melanoma? Do you think it's a neuroendocrine tumor? Can you tell me, Aishwarya?
Ma'am,
So I'm asking you a
ma'am.
question. So would you consider this a poorly differentiated tumor? And if so, where does it fit? Is it monomorphic? Is it pleomorphic? And if it is one or the other, is it epithelioid? Is it mesenchymal? Is it small cell? Now come on. I'm giving you a system, Aishwarya. So come on. People are seeing differentiation over here. We are being on the chat box. They're calling something Hodgkin and all sorts. Yes. Come on, Aishwarya.
Ma'am, I think this is a pleomorphic population. I can.
You think it's pleomorphic? All right. There is some degree of pleomorphism. I won't say there is none, but it's not marked variation. Do you think, Aishwarya, it's marked?
No, ma'am, not marked.
No, it's not marked. All right.
Yes, ma'am.
Right. So then what? All right. But what is it? Is it epithelioid? Is it mesenchymal? Is it round cell? Is it what?
Ma'am, this is epithelioid.
Epithelioid. Very good, Aishwarya. And this is how, my friends, you have to do your daily diagnostic work. All right. It is epithelioid. It is not very pleomorphic, but it is epithelioid. Okay. So now you think that this is a poorly differentiated tumor. That means on morphology. I don't know what this is. Somebody said Hodgkin's. Yes, it could be lymphoma. It could be anything. All right. But it is poorly differentiated. And I have to now do some ancillary technique to find it out. So what ancillary technique should I do? Immunohistochemistry. Yes. It's epithelioid.
Yes,
So what's the
I
first thing I should do?
Pancytokeratin.
Pancytokeratin. There it is. It's positive. So now tell me, what is it?
Epithelial origin.
It is a what? It's epithelial. Very good. But what
Epithelial
epithelial? Oh, thank you. Yes, Sneha. But what epithelial origin? Like, am I going to write poorly differentiated tumor of epithelial origin? What is your diagnosis, Sneha, in this case? Huh? What? Anybody? Well, it's a carcinoma, right? So it is a carcinoma. And the question, now we know that this poorly differentiated tumor is a carcinoma. It's malignant. There's no two ways about this. It is a carcinoma. Now I have to figure out what this carcinoma is. So now tell me, Aishwarya, what should I do next? How do I, it's a metastatic carcinoma in a lymph node, in a young adult's neck. So what are those carcinomas that metastasize to lymph nodes? Come on, Aishwarya, or Deepak, I can see you right there. No, Deepak, Lalit, not. You know any carcinomas that metastasize to the lymph nodes in the neck? Come on, all of you except for Navneet are third year. What? No, Lalit, you don't know.
Ma'am, a small carcinoma will do
Squamous cell
P40 and
carcinoma.
P63.
Yes, excellent. So could this be a squamous cell carcinoma? And how would I know that this is a squamous cell carcinoma? I don't see keratin. I don't see, big broad cells with desmosomes and all this. So what is the next immuno that I should do to know whether this is a squamous carcinoma? P63. So there we are, P63. So now this is a squamous carcinoma. Yes, Deepak?
Yes, ma'am.
Yeah, you think so? Now you look at the carcinoma again. Look at the H&E. You ever seen squamous carcinoma, Deepak or Aishwarya or anybody with big fat nucleoli, big vacant nuclei with big fat nuclei? Can you see nucleoli? Can you see or not? Of course they're there.
Yes,
So
ma'am.
then which is that carcinoma which will be poorly differentiated, which show you squamous markers? There is a carcinoma, CK is positive, P63 is positive, and occurs in the lymph node of a young adult. It's obviously metastatic, so it's metastasized. So which is that? There are lots of people are saying things in the chat box. Somebody said lung. I think that's terrible. Okay. Squamous carcinoma of the lung, no. Megha is saying something and others have said it before. It is nasopharyngeal. Nasopharyngeal carcinoma. And what would you do? You would do an EBA. And there you are. Or Epstein-Barr virus induced squamous carcinoma. It's basically in the squamous epithelium. But this is a poorly differentiated malignant tumor, which is expressing pancytokeratin, P63, and EBA. So what is that diagnosis? Yes, Aishwarya?
Nasopharyngeal.
Undifferentiated carcinoma of the nasopharynx. So NPC, as a lot of people are saying. Okay. So this is what this tumor is. Now we have some very funny terminology, right? This thing was looking very poorly differentiated. Okay. There was nothing there when we first looked at it. Now we have proved that it is a carcinoma. And we know that it is a squamous carcinoma. And yet, we're calling it an undifferentiated carcinoma of the nasopharynx. So why are we calling it an undifferentiated? Anybody would like to say why are we calling it undifferentiated? We should be calling it a polydifferentiated carcinoma of the nasopharynx that is associated with EBUS. Well, the real terminology should be that PDC with EBUS. But from the time that this tumor was recognized, before they even recognized that it was coming from squamous epithelium, before they even recognized that this was EBUS positive, we knew that it was a carcinoma and it had no differentiating features. It never showed you frank squamous differentiation, and that's why this term has stuck. It's undifferentiated carcinoma of the nasopharynx or nasopharyngeal carcinoma of lymphoepithelioma type, because often it has a lot of lymphoid tissue in even its primary site in the nasopharynx. And now we know that it is EBUS and we know that it is P63 expressing, and therefore the squamous epithelium is when it is infected by Epstein-Barr virus, this is the kind of histology which is extremely poorly differentiated with these big cells, nuclei full of nucleoli, which you normally do not see in standard poorly differentiated squamous carcinoma. So this is the term that is given. So now we have to ask the question, what is an undifferentiated tumor? Okay, we suddenly come up with this term now. And I told you right at the beginning that when we use this term poorly differentiated, people use it for all sorts of things. And we've been using it so far for tumors in which morphologically I cannot see any differentiations. Okay. And now we have even used it for a tumor which we're calling undifferentiated. It's an undifferentiated tumor. Therefore, we have to understand what we mean by undifferentiation. And really, this undifferentiation has got nothing to do with immunohistochemistry. Okay? It is how it looks morphologically. So we call it undifferentiated tumor of the nasopharynx because it is arising from squamous epithelium and it never shows you squamous differentiation. That's number one. Anaplastic carcinoma of the thyroid. Today we call it an undifferentiated carcinoma of the thyroid. Looking at it, it looks like a sarcoma. It does not show you a differentiation into thyroid follicular epithelial cells. So this is truly undifferentiated tumor. And in the soft tissues, okay, you have an undifferentiated pleomorphic sarcoma. We know it is a sarcoma because it's not a carcinoma, it's not a melanoma, it's nothing else. We know it is a sarcoma, but you cannot see differentiation in that tumor. Okay, so the lineage may then be determined by ancillary techniques like we just saw pan-CK for a carcinoma. So this is how we should think of how to use this term undifferentiated malignant tumor. Okay, very good. Now here's a tumor in the gingival-buccal sulcus. Here you can see on top the squamous epithelium, and it's a tumor that is gone into the fat, because in the gingival-buccal sulcus the fat is, you don't get too many muscles, so you've got fat right down there, and you can see the tumor. The tumor is like this. Anybody want to say what this tumor is? Are you going to call this a poorly differentiated tumor? Is Deepak back or is Deepak disappeared? Deepak, are you there?
Yes, ma'am.
Right. Are you going to call this an undifferentiated tumor? Sorry, a poorly differentiated tumor? Deepak, just say yes or no.
Yes,
Don't
ma'am.
go off the air. Can you
Yes,
see
ma'am.
any differentiation in this tumor? And if you do, tell me what kind of differentiation you see.
Mesenchymal
Mesenchymal. So
differentiation.
that's not mesenchymal differentiation. It's a mesenchymal pattern. Yes. So that's what you are seeing. Something that is looking very sarcomatoid. Yeah. Until you go to the right-hand side of this lesion, and there you see something else. What are you seeing there, Deepak?
Yes, ma'am.
Anything? There. This is the right-hand side of that picture. What are you seeing? You saw, yes, there is a mesenchymal pattern. I'm absolutely, happy that you saw the mesenchymal. Look at these. These are all spindle stellate cells. Okay, but what are you seeing here? Mesenchymal to you, Deepak? Sakshi, what are you seeing?
There is some epithelioid pattern there.
Yes, what kind of epithelioid? Sorry? Adeno. So you're seeing gland-like differentiation, yes or no? You're seeing gland-like forms. I'm not saying that these are two glands, but you're seeing gland-like forms. Can you see it or not? There's a central lumen, then you have things around the periphery. So there is something that is gland-like or spaces anyway. You're seeing spaces with some very ugly looking cells that are surrounding the spaces. So you're seeing mesenchymal pattern and something that is looking epithelioid. You're right, Sakshi. Very good. See, you can see the two things together here. You see these spaces which look epithelioid, yes, okay, forming some gland-like patterns, and you're seeing this mesenchymal-like tumor. So I see a biphasic pattern, okay, and I don't know what it is. This is in the buccal mucosa, and I'm seeing a biphasic pattern. It could be many things. It could be sarcomatoid squamous carcinoma. It could be an angiosarcoma because there are spaces being formed, etc. So now it is not showing me any kind of clear differentiation. So it is a poorly differentiated malignant tumor. So what is this poorly differentiated malignant tumor? We have to find out, okay? And that's what we did. It is also P63 positive. I put the wrong slide over here. Then this is pan-CK. So this thing is an angiomatoid, pseudoadenoid, whatever you want to call it, squamous carcinoma. Okay. Now, would we call this a poorly differentiated squamous carcinoma? Come on, I can see somebody over here. Yes, Aradhana, can we call this a poorly differentiated squamous carcinoma? It's a squamous carcinoma.
Yes, ma'am.
Yes, of course you can.
Yes,
This is a poorly differentiated squamous carcinoma. You want to use these other terms, angiomatoid, pseudoadenoid, some may even call it sarcomatoid. That's fine, but it is indeed a poorly differentiated squamous carcinoma. And you can see all those pseudoadenoid structures all having taken up the pan-CK, and they were all P63 positive. So yes, you can certainly call this a poorly differentiated squamous carcinoma, high-grade squamous carcinoma, sarcomatoid squamous carcinoma, whatever you want, because this is a tumor now. It was poorly differentiated when we first saw it, and after we proved that it is a squamous carcinoma, we still want to retain that term poorly differentiated, except that now we will call it a squamous carcinoma. All right. Any questions about that? Yes. What is the question?
Biphasic and biphenotypic, same terminologies.
Yeah, biphasic and biphenotypic is the same terminology, provided you can use it. Biphasic is not used for something with immunohistochemistry. Biphenotypic can be used for morphology as well as for immunohistochemistry, because like you can get biphenotypic leukemias in which the leukemia is showing you the immunophenotype of both myeloid or lymphoid or whatever. Biphenotypic can be used for morphology as well as for the immunoprofile. Biphasic is only used for morphology. Okay, you can't say it's a biphasic leukemia.
Other
All right.
questions, ma'am.
All right. So differentiation. Now here, what I wanted to tell you is this is about neuroendocrine tumors, okay? And this is an H&E. And what I want to tell you is, once again, we've seen it before. That I know that this is a neuroendocrine tumor because I have learned over the years to recognize a neuroendocrine tumor. That this has got islands, it is in the small bowel, etc. But this does not look at all like neuroendocrine cells. And you find the neuroendocrine cells, which are small individual cells that are present in the small bowel, and this tumor doesn't look like them at all. Okay, we've seen that before when we were trying to when we saw the pleomorphic adenoma. The pleomorphic adenoma didn't look like any normal salivary gland structure. And here is a neuroendocrine tumor. Okay, and this didn't look like anything. It's looking like cords. Here it is showing you rosettes. Here it is in sheets with a vascular pattern. But I recognize these as being neuroendocrine morphology, just as I recognize this, which we saw before, as a small cell carcinoma, which also has neuroendocrine morphology. But if you're asking me, is this differentiation? No, in the sense that these tumors, if you see sheet-like tumors, or like we saw in the small cell carcinoma, or these ribbons, etc., if you might even see ribbons, etc., in a hepatocellular carcinoma. So we have to prove that this is really a neuroendocrine tumor, and we do that by immunohistochemistry. Here is how we do it. We also sometimes have to use other markers, and here is INSM1, which in this case is a neuroendocrine tumor because although it is not CK positive, there's INSM1 positive. And we are now being asked in neuroendocrine tumor pathology to recognize what is well differentiated. And I showed you all those pictures of a well differentiated neuroendocrine tumor from something that is a neuroendocrine carcinoma. Okay, so we have NETs and we have NECs. And the carcinomas have a poorly differentiated morphology. Now, what is this poorly differentiated morphology? It's what is not what we consider well differentiated morphology for neuroendocrine, and we have to recognize well differentiated morphology as what I showed you before. Okay, so it doesn't look like it's the normal counterpart because the normal counterpart are just single cells, but we have come to recognize what I showed you before as being neuroendocrine morphology. Now here we come to a situation like this. Yeah, it looks well differentiated. It looks as if it should be a neuroendocrine tumor, but it is not. It is really a poorly differentiated neuroendocrine tumor because it does express neuroendocrine markers. It's got a very high MIF and it has lost RB1 protein. Don't worry about this from the point of view of your postgraduates, but I thought I should bring this in because there are people who are not postgraduates who also attend these talks. Okay, so what we now have to come to tumor grading, and tumor grading is often based on differentiation. It's not only based on differentiation, but please understand that the tumors that are usually graded and graded on the basis of differentiation are carcinomas, sarcomas in soft tissue and bone, some blastomas like neuroblastoma, and I showed you an example, sex cord tumors, some gliomas, and some lymphomas, but they're not called poorly differentiated lymphomas. We call them high grade and low grade. But there is a whole lot of tumors that are never graded. Okay, we don't grade Ewing sarcoma, we don't grade alveolar soft part sarcoma, we don't grade BCOR or chick ducts related. We don't grade germ cell tumors except the ones that are immature, in which we say grade 1, 2, 3. We don't grade the ones that have lost INI1 or BRID1, and most blastomas and those with DICER mutated tumors are not graded. It's because, and if you look at this whole list that I put on the ones that are not graded, they are tumors that have got some, sort of specific fingerprinting, either mutations or gene variations. Okay, like this tumor, which you see over here. This is a 2-year-old rapidly growing mass in the neck, right? And it's almost undifferentiated, or you would call it a poorly differentiated malignant tumor. It's lost INI1. And therefore, it is a malignant rhabdoid tumor. So look at all of these on the right-hand side, and they all have nowhere would you be able to take the tumor and sort of relate it to some particular cell in the body. Okay, you can't do this. You can't do this for Ewing's sarcoma. Where's the Ewing sarcoma? What is the cell of origin that you can say, oh, this is a poorly differentiated variant of this particular cell? And I think that the grading of soft tissue tumors, which is done on differentiation score, yes, you can draw a line over here. I've drawn that line, and you see everything below that line is a differentiation score 3, except for this one, which is a well-differentiated conventional angiosarcoma. If you go above the line, there are many 1s, 2s, and 3s, and then look carefully at what is below the line, and you'll see that most of them have got some translocation or mutation, and including synovial sarcoma, which makes it a differentiation score 3. That means they don't have any way that you can relate it to a particular cell type from which, or a histogenetic type from which it arises. And I'll just tell you something very interesting. Postgraduates may be interested in it or not. If you take all soft tissue sarcomas and you look at Ewing sarcoma as an example, and leiomyosarcoma of the other example, and you look at all these tumors, okay, those with translocations, they seem mainly in children. They are monomorphic. They are never graded. They are lineage obscure. You don't know what their lineage is. They are never associated with radiation. They are not seen in these sarcoma syndromes. Okay, Lee-Fraumeni or RB syndrome. You will never get one of these translocation-associated tumors, and they are not P53 associated. The tumors with like a leiomyosarcoma are tumors with very complex karyotypes. They're not fingerprint type tumors with translocations or, like I said, a mutation of one type. They're seen in adults. They can be very pleomorphic, and we grade them. We say low grade and high grade leiomyosarcoma. We know their lineage, but we can show the lineage on immunohistochemistry or even by looking at the tumor. These are the tumors that you get in post-radiation situations. Whether it's leiomyosarcoma, fibrosarcoma, angiosarcoma, whatever. And they are regularly associated with familial syndromes like the Lee-Fraumeni syndrome. In RB syndrome, occasionally you do get osteogenic sarcoma, and they are very regularly P53 associated. So I just thought I would tell you this because this is relevant to the topic that I'm taking. And this should not be a difficult thing. It's just put up because I want to know what is the fourth picture. It's an immunohistochemistry. All right, Navneet, are you there?
Yes, ma'am.
All right, quick, Navneet. This is a what kind of tumor? Where does it fit in our patterns?
Some poorly differentiated.
Yes, but what's the pattern?
Round.
Round cell. So it's monomorphic and it's round cell. Yes. Yes. Now, is it monomorphic and round cell, Navneet?
Yes, ma'am.
Very good. We've done CD99, which is also called MIC2. Now, what do you think this immunohistochemistry is? These are all nuclei that have got taken up the stain. This is CD99, which you can see is membrane, because you can see the nuclei have not taken up the stain, and you can see the membrane stain with the unstained nuclei. Here, the nuclei have got the stain. So what is this antibody that has been used? No idea? All right. Lalit, what is the antibody that has been used? Yes? No? Do you know what the diagnosis is, Lalit? What's your diagnosis? The diagnosis is straightforward, no? It is a Ewing sarcoma. Right. So what is the antibody that proves that it is a Ewing sarcoma? CD99 is positive in many tumors, yes?
Ly1.
No. NKX2.2.
Yes,
All right. So this is NKX2.2. So this is a poorly differentiated, you might even call it an undifferentiated tumor on morphology. But when we do our immunohistochemistry, you see it, it's a Ewing sarcoma. Okay. Now I have a question to ask you guys. Does a well-differentiated tumor progress to a poorly differentiated tumor over time? Let me hear your answers. Sneha, what do you think? I have a well-differentiated tumor. I don't do anything about it. I just sit on it. Will it become poorly differentiated over time?
Yes, ma'am. Mutations will accumulate, more mutations will accumulate, and
it will become a poorly differentiated tumor. All right. Let's ask Aishwarya. What's the answer to that? Aishwarya? Aishwarya is not there. Deepak? Just say yes and then don't answer is all right. But are you there?
Yes, ma'am.
Yes. So tell me, what do you think is the answer to this question? People are answering
ma'am.
yes and no in the chat
Yes,
box.
ma'am, it will progress. to
Yes.
body
Okay. Very good. Amrita.
Yes, ma'am. It will progress.
Yes. Aradhana.
Yes, ma'am.
Yes. Okay. Sakshi.
Ma'am, it may or may not progress.
All right. Good. Navneet.
Yes, ma'am, it can progress to body differentiation.
Can is a different thing. Does it, or like Navneet said, may or may not? So what are you saying? Can? Yes or no?
Yes,
Do
ma'am.
you mean may?
May, ma'am. It may.
May. All right. Lalit.
Ma'am, it can.
You are again saying can. All right. The answer is both yes and no. And the context is very important. So please remember this. No, if I sit with a breast carcinoma, which is well differentiated tubular carcinoma, and I sit on it, for years, will it turn into a poorly differentiated grade 3 carcinoma? The answer is no. But the context is important. See, neurofibromas in the context of neurofibromatosis (NF) do progress to MPNSTs. This is because of the milieu that is there. Because there is a mutation in these patients, which you have the NF mutation, and they do progress. Some tumors like dermatofibrosarcoma, oh god, there's a spelling mistake there. Dermatofibrosarcoma, they do so after several recurrences. So they come back again and again, and then they turn into a high-grade sarcoma. Okay, but by and large, no. A dermatofibrosarcoma, if it does not recur, or it recurs once or twice, it is not going to turn into a high-grade sarcoma. And even if you sat on a dermatofibrosarcoma for years, it possibly will not turn into a. But dedifferentiation in high-grade progression occurs in some tumors with some degree of regularity. Yeah. So tell me, anybody can tell me which dedifferentiated tumors have you heard of? I can see liposarcoma. Yes, very good. Anybody else wants to give me an example? Well differentiated progresses to liposarcoma. Anybody else? No examples, not even in the chat box. Well,
No,
these,
it's not it.
we'll okay.
Thyroid tumor.
Huh?
Thyroid tumor they have mentioned.
Yes, thyroid does it. No, if you hatch a follicular adenoma, follicular thyroid carcinoma for a long time, yes, over a period of time, it will become polydifferentiated and then anaplastic. Chondrosarcoma. Excellent. So, but most other tumors, let me tell you, show distinct low and high grade pathways of development, including breast, ovarian, neuroendocrine tumors, a low grade neuroendocrine tumor, or what we call NECT, does not become a NEC, neuroendocrine carcinoma. So you start off with a well-differentiated neuroendocrine tumor, grade 1 doesn't become a small cell carcinoma because there are different pathways, and de novo the cell is committed to one of the other pathways. So please, those who are interested, go and read about the pathways in breast. In ovarian tumors, it is very, very interesting. But particularly for serous tumors, you get serous cystadenoma, borderline, and well-differentiated or low-grade serous carcinomas. They form a continuum. But a low-grade serous carcinoma will never become a high-grade serous carcinoma. If that doesn't do that, high-grade serous carcinoma starts as a high-grade serous carcinoma de novo. Okay, so we have to ask, what is dedifferentiation? Okay, and dedifferentiation you have to define as progression or conversion of a benign or a low-grade malignant tumor into a high-grade tumor, which is undifferentiated. You would never even dream that this tumor has actually come from that well-differentiated tumor, which is undifferentiated, or it manifests a high-grade differentiation other than that present in the original tumor. So you have a low-grade chondrosarcoma, you have an enchondroma, and it ends up looking, dedifferentiating to an osteogenic sarcoma, right? Similarly, you have a nice giant cell tumor, and after some time, it may become an osteosarcoma. So that is what we mean by dedifferentiation. And what is happening in dedifferentiation? It's not as if the well-differentiated component has become, has reverted and sort of become stem cell-like. No, it's just that the stem cell that is giving rise to the differentiation now stops differentiating and becomes very malignant. It is no longer the kind of differentiation that you expect because there's been a change in that stem cell. It now has no differentiation to talk about. Okay, so you must have evidence of the previous benign or low-grade tumor should be available on morphology or on ancillary techniques. And he mentioned liposarcoma, which is that turns into this. There are some molecular markers, right? And we can do those molecular markers and show that this was once upon a time a well-differentiated liposarcoma. Now it is expressing MDM2 either on immunohistochemistry or on FISH. There is amplification. So this progression is usually abrupt, and I'll show you some examples. Dedifferentiated chondrosarcoma, liposarcoma, carcinoma, X-pleomorphic adenoma. Okay, and you have dedifferentiated endometrioid adenocarcinomas. We're seeing it. Here is a beautiful example of a retroperitoneal tumor, very, very undifferentiated on the right side, or extremely poorly differentiated. We don't even know what it is. It's infiltrating fat, and you might think, oh, maybe this was well differentiated, but we have to prove that it is so. And here is MDM2, and this was also MDM2 amplified on FISH. So here is liposarcoma, which is dedifferentiated liposarcoma, right? Here is a biopsy that is taken from the maxilla, from an oroantral fistula, from the maxillary sinus. And anybody wants to tell me what this middle picture is? You can see the white line is what you're seeing on the right hand side. Anybody? What would you call this this thing? It looks like a jigsaw puzzle that has been shaken, no? And that is what we call a stellate reticulum. This is an ameloblastoma. And that ameloblastoma, which is so beautifully differentiated, and you can see in the middle over there, this has gone under high-grade transformation. You can see that the CK is present everywhere except in that region, and the MIB1 is low everywhere except MIB1 is the proliferation index, and it is high only in that central portion of the tumor. This is dedifferentiation in an ameloblastoma. Okay, so we would call it progression or high-grade transformation of an ameloblastoma that is dedifferentiated. And here is a hysterectomy for an endometrial carcinoma. You can see the beautiful differentiated endometrial carcinoma on here. The complete lack of differentiation has just become like a round cell tumor. That's how it well differentiated. It looks in the better differentiated parts, and this is how. So this is a dedifferentiated endometrioid adenocarcinoma. You can see the endometrioid adenocarcinoma on top. So I think that we have come to the end of this this presentation. I'll just leave you with a summary. And the question that somebody had asked will be answered over here. The term poorly differentiated, although we keep using it all the time, should not be used for undifferentiated or undefined tumors. But we do it. Okay, and I showed you that on morphology, when we can't see differentiation, we refer to this. We call it poorly differentiated malignant tumor, or even just a poorly differentiated tumor. And like in the case of the GIST, that was not even malignant, but it had no differentiation that could say that that was a gist until we did immunohistochemistry. Okay, an undifferentiated tumor shows no morphological features of differentiation. Okay, it may show expression of lineage markers on immunohistochemistry, but it shows absolutely no morphological features of differentiation on your H&E. Now, a tumor of undefined histogenesis, for which we often use this term, poorly differentiated, on morphology may be well or poorly differentiated when its nature is revealed by ancillary techniques. And I showed you an example of a gist. Okay, it also happens in neuroendocrine neoplasms. You don't know, it looks odd. I don't know that it's a neuroendocrine neoplasm. And when I actually do the immunohistochemistry and I know that it is a neuroendocrine neoplasm and it is well differentiated, I am, it may turn out to be what we call low grade. Okay? But most often these undefined tumors turn out to be poorly differentiated. And what is a dedifferentiated tumor? It has both differentiated and undifferentiated components, in which the undifferentiated component is abrupt and distinct from its differentiated component. You saw that in the endometrial tumor. See, abrupt. It doesn't really normally get admixed. The carcinosarcomas, yes, but this kind of dedifferentiation is not seen. You can see this abrupt, just an abrupt differentiation that you would like to see. Okay, I think that's the summary, and I have finished. It's been a long time. I thought I finished very quickly, but I found that there were lots of things that needed an explanation, and I must say that all of you have been very, 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 very good. Let me stop the sharing over here and see all of you. Okay, so are there any questions that you would like to ask, or has everybody now understood everything? What? Any questions? Are there questions in the chat box that need to be answered?
Two more
Yes.
questions are there. In
Yes,
tumors with different grades of differentiation, how to grade it?
The tumors with different grades of differentiation. I'm not sure what that person means. Like, you know, you know that every day we see squamous carcinomas. All of you probably see it. Then one portion of the tumor will be well differentiated. Another portion of the tumor may be poorly differentiated. Okay, so what do? There are grading systems, okay, which tell you how much of the tumor is, as far as squamous carcinoma is concerned, is well differentiated. You know, like the old Broders, 25, 50, 75, 100%. So today we don't use Broders as much as we used to. We use today, you know, a different kind of grading system where we are actually looking at the worst pattern of invasion, and we can put that all together in a grading system. So there is going to be some tumors that are better and some tumors that are less differentiated within the same tumor. It happens in the breast, and that's why we count. You know, we give scores to the number of tubules and so on. So if you have a clear, you know, sort of undifferentiated tumor like I showed, you know, so you can't call it well and undifferentiated. We just call this de-differentiation. So it's a good term, de-differentiation in a otherwise well differentiated tumor. I don't know if that answers the question, but whoever is it can ask the question again if there is some clarification that is needed. Any other question?
How to typical mitosis?
How to differentiate it typical and atypical mitosis. Well, what is a typical mitosis? First of all, I think people should realize that a mitosis never occurs in an intact nucleus. Okay, so if you have a nuclear membrane, what you're seeing inside is not a mitosis. Number one, the nuclear membrane has to dissolve before mitosis actually starts, because you cannot get division of your chromosomes before dissolution of the nuclear membrane. Okay, so that's the first thing. The second thing is that you need all the normal figures that we are, you know, you have metaphase, you have, you know, telophase when it goes there. These are all normal, and then only whenever the thing is dividing, you'll see only two. You know, it goes to one end, then it goes to the other end. If it's metaphase, it's just one curly line in the center. Okay, or in the prophase, you have a burst. Okay, the thing just bursts like that, and you get like how you see fireworks in the sky. You get a burst. Okay, that's not abnormal. So the burst, the metaphase, the telophase are absolutely normal. So you have to familiarize yourself with that. So what is an abnormal mitosis? It means that you have, you know, instead of having two telophases, you start to get, you know, 4 or 3, or so that's why we call it polar. So it's a bipolar mitosis is normal. Dipolar, quadripolar, pentapolar, whatever, that is abnormal. So just some chromosomes here and there, you know, lying inside a cell does not make it an abnormal mitosis. Okay, so you have to familiarize yourself with what normal mitotic figure looks like, or figures look like, and then call it normal or abnormal. Any other question?
How can we differentiate between undifferentiated or dedifferentiated tumor if don't have history and morphology of previous tumor?
Well, you have to make an attempt. You know, you have to make an attempt. Now, if I have a tumor, and I'll give you a good example. Right? Somebody came from one of the teaching hospitals, and it was a very long time ago, so it's not on, you know, anybody who's there now, and brought slides. Okay, slides of a very undifferentiated sarcomatoid-looking tumor, and wanted to know what sarcoma it was. And where was this tumor? The tumor was sitting in the suprahyoid triangle, you know, where you have just under the mandible, where you have the submandibular salivary gland. And I asked that person, this was an exception because there were lots of big sections. So I said, what was the status of the submandibular salivary gland? And that person said there was no submandibular salivary gland. And I said, it is not possible for anybody to resect a big tumor in the region of the suprahyoid triangle and leave the submandibular gland behind. Okay, but of course they swore, no, we didn't see it. I said, may I have a look at the specimen? So they came with the specimen the next day. And when I saw that specimen, it was cut into half like this. And sections, like many very often are just taken off the surface of this tumor. So I picked up a knife and I was going to cut into that. And no, there was consternation. No, because you want to keep it in your museum. Okay, but I took the knife and I sliced it, and sitting in there, okay, was, guess what? What was sitting in there? Tumoric adenoma. Okay, so when you say that I don't know what was there before, it is there in front of your eyes, but you have not really looked for it. Okay, so here was a submandibular salivary gland pleomorphic adenoma, which had started to get very hyalinized, and it had become a sarcomatoid carcinoma, which is a carcinoma ex pleomorphic adenoma. It can be a duct carcinoma, it can be this kind of carcinoma. So I think that efforts have to be made to find out what the tumor was before, based on what you are seeing now, the location where you are seeing it, and a good dose of clinical acumen. All of you, every one of you should be a clinician first and a pathologist added to that. So to see how good we are. We are clinicians and we are pathologists, and nobody can beat us at that game if we say to ourselves 100 times in a day, I am a clinician first. Yeah, we all came there, no, with our MBBS, and then you will not have this problem which somebody is asking now. Any other question?
One last question, madam. If there is
Yes.
a situation arise when no
Yeah.
IHC helps, how to report in such cases?
When no IHC helps, it happens all
Helps.
the time when no IHC helps. So then you have got an undifferentiated malignant tumor. If it is malignant or an undefined tumor of whatever, it doesn't help. There are so many situations in which it doesn't help. You just have to be as, if it's a malignant tumor, you can say whether it's high grade, low grade or not, which I do so often. I don't know what it is, but my immunohistochemistry has helped, but I do know that it's a sarcoma and it's a low grade sarcoma. So I'd say so. What's the problem? You just have to confess that you can't know everything. Yes.
That's all, ma'am.
That's all. Oh, very good. So that is not too difficult. Any questions from my eight students? I own you. I think that I'm so happy that you are here and you answered the questions. Sometimes it's difficult to do this, but you've done it on behalf of all the the students and others who have listened to this lecture. So they have learned from your answers, from your mistakes, and I thank you very much for that, because being front and center can be a very unnerving thing. So thank you, all of you, very much. Lalit,
Thank you,
and,
ma'am. Thank you.
not at all. And Navneet
One
and
more thing I just
Sakshi
want to
and-
tell.
Yes.
That you have got a magical, powerful voice, man. And the way you are teaching is very amazing. Trying to know
Thank you,
from
Diff.
students'
But actually
mind and then correcting them will have a huge impact on their understanding. Not only on the students, but those who are listening also will have a great impact on them. It's very amazing. It's very nice hearing from you. Thank you so much.
Tripura, you know that I was a student once, and when I was a student, when I didn't understand, I now understand how students don't understand. So that's all that I can say. But thank you very much, Tripura, for that. Okay, so thank you all of you, Deepak and
Thank you.
Amrit.